Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator and practicing cardiologist. So as a part of the INI-CET revision series, today's topic for revision will be some neurological problems. So I'll give you the various clinical scenarios of the neurological conditions and you should be able to diagnose that. So please answer this question in the comment section wherein I'll reply you back. The chromosomal abnormality in neurofibromatosis type 1 is chromosome 17, 22, 19 and 14. So please answer your question in the comment box. So definitely I'll revert back to you with explanation. And before going ahead with the detailed clinical diagnosis of the various neurological problems, if you did not subscribe to this channel, please subscribe to this channel and press on the bell button. So let us start with the various neurological problems. So these are all the various neurological problems and these are the options that you have. So you should be able to fix one particular diagnosis. So the first clinical scenario is a 45-year-old woman complains of pain behind the ear and that her mouth is sagging on the right hand side. So this is the clinical picture. So among the options which has been given to you, like what is the true statement or what is the diagnosis? So the options I'll read once. That includes muscular dystrophy, Shy-Drager syndrome, chronic fatigue syndrome, neurofibromatosis, myasthenia gravis, melanoma, Sturge-Weber syndrome, Syringomyelia, Pseudo-bulbar palsy, Bell's palsy, and then cervical spondylolisthesis. Now, so the very important point here is 45-year-old woman, that is fine. Her mouth is sagging on the right side and that too there is a pain behind the right ear. So this is a classical picture of the lower motor neuron facial palsy. And among the options which has been given to you, in which clinical condition you have lower motor neuron type of facial nerve palsy, that is in case of the Bell's palsy. So the clinical diagnosis is the Bell's palsy. And in case of the Bell's palsy, what will be the clinical manifestations? There will be ipsilateral, half of the face is paralyzed. Right? Ipsilateral, half of the face is paralyzed. So if you can observe this in the image, the individual will not be able to wrinkle the brow. There will be drooping of the eyelid and inability to close the eyes, that is due to paralysis of the orbicularis oculi muscle, and inability to puff the cheeks because the buccinator is paralyzed. Drooping of the mouth and inability to smile or pucker, that is because of paralysis of the orbicularis oris. And in these patients with the Bell's palsy, along with these manifestations, there will be also loss of the taste sensations on the anterior 2/3 of the tongue. So why is that? Because this anterior 2/3 of the tongue is supplied by the chordae tympani. The sensory sensations is by chordae tympani, which is the branch of the facial nerve. So once the facial nerve in the Bell's palsy is paralyzed, the taste sensation is also lost. And how is the prognosis in these patients with the Bell's palsy? Almost 95 to 99% of individuals, they'll have complete recovery. The prognosis is good. And anyways, the outcome completely depends upon the electromyography. Right? So that is a very good predictor of the outcome. Now, you should also know the differences between upper motor neuron lesion and lower motor neuron lesion. So in lower motor neuron lesion, what did I tell you? Right? I have said you that there will be ipsilateral, half of the face is completely paralyzed in case of lower motor neuron lesion. Whereas in case of upper motor neuron lesion, what will be the features is contralateral lower half of the face is paralyzed. So you see here, this is the part of the face which is paralyzed in this individual. So that is on the right side. So which UMN palsy this individual might be having? This individual might be having left UMN palsy. Okay, so the upper half will be spared, only the lower half of the face will be paralyzed. Whereas in lower motor neuron lesion, it is ipsilateral half of the face which will be paralyzed. And in this lower motor neuron lesion, which is nothing but Bell's palsy, you have classical Bell's phenomenon as well, where there will be upward and outward movement of the eyeball when the individual is trying to close the eyes. That is what you will see in lower motor neuron lesion. Next, Now, coming to the next clinical picture. A 62-year-old woman presents with stiff spastic tongue and a Donald Duck-like speech. On examination, she had a brisk jaw jerk and was prone to laughing inappropriately. So what is this suggestive of? Now, if you take the spasticity, it is the upper motor neuron sign, right? And brisk jaw jerk, this is also an upper motor neuron sign. And why is this Donald Duck like speech? That is because of the spastic tongue. So among the options which has been given to you, like which of the following has the upper motor neuron palsy, that too within the face? You will have that in case of the pseudo-bulbar palsy. So pseudo-bulbar palsy, it is an upper motor neuron lesion which is caused by bilateral lesions of the lower cranial nerve nuclei and can be associated with emotional lability. Now, if you take the clinical picture of our patient is like prone to laughing inappropriately. So that is the emotional lability. And what are the conditions where you will have the pseudo-bulbar palsy? You will have this pseudo-bulbar palsy in conditions like multiple sclerosis, motor neuron disease, and as well as the bilateral stroke. So that is about your pseudo-bulbar palsy. Next, you take the third important clinical picture. A 27-year-old woman presents with wasting and weakness of the small muscles of the hand. Examination reveals the loss of pain and temperature sensations over the trunk and arms with intact vibration sense. So if you see this clinical picture, how is it? Now wasting and weakness of small muscles of the hand. So this is the motor function which is being lost. And loss of pain and temperature, that means your spinothalamic tract sensations are lost. There is intact vibration sense, that means the dorsal column sensations are being present. So what is this type of anesthesia? We call it as dissociative anesthesia, where there is loss of pain and temperature, but there is intact vibration sense. Now, in which clinical condition you will have this particular findings? You will have these findings in case of the Syringomyelia. Now, what is Syringomyelia? Syringomyelia, it is the one which is characterized by the presence of the fluid-filled cavity within the spinal cord. And which part of the spinal cord is most commonly affected is the cervical spinal cord is the most common part of the spinal cord which is affected with Syringomyelia. And what is the etiology, or in which conditions you will have this development of Syringomyelia? Very, very important question. It is associated with Arnold-Chiari malformations. Now, in case of the Syringomyelia, like we have discussed, that there will be presence of the syrinx, which is nothing but the fluid filled cyst that is present in the center of the spinal cord. And this fluid filled cyst, that is syrinx, whenever it expands, it compresses the spinothalamic tract, right? So these are your spinothalamic tracts. So it compresses the spinothalamic tract, but you take the dorsal columns, that will be intact. Right, dorsal columns will be intact, and even your corticospinal tract, that also will get compressed. That also gets compressed, but in the later stages of Syringomyelia. So because the corticospinal tract is gone and because the spinothalamic tract is gone, there is loss of pain and temperature sensations due to spinothalamic tract, and there is wasting and weakness of the small muscles of the hand, that is due to involvement of corticospinal tract. Now, then this characteristic distribution, right, this characteristic distribution of loss of pain and temperature and sensation, it is called as the cape-like distribution, right? It is called as the cape-like distribution of the loss of pain and temperature over the arms and as well as a part of the trunk. And in these individuals with Syringomyelia, very, very important finding is that there will be sensory loss, and this sensory loss can result in the development of Charcot's joint. So this is what is your Charcot's joint. So what is this Charcot's joint? It is the neuropathic joints damaged through loss of sensation, right? Neuropathic joints damaged through loss of sensation is what is called as the Charcot's joints. And in these patients with Syringomyelia, there can be involvement of the cervical sympathetic trunk also, and that will result in the development of the Horner syndrome. So what are the components of Horner syndrome? There is ptosis, where there is drooping of the eyelids, meiosis, where there will be constriction of the pupil, and anhidrosis, where there is loss of sweating, and they also have enophthalmos. So what is this enophthalmosis? Enophthalmosis is inward movement of the eyeball. That is what is called as enophthalmosis. And finally, there is loss of ciliospinal reflex. Right, there is loss of the ciliospinal reflex. So this is what is nothing but your Horner syndrome, and that can be there due to compression of the sympathetic trunk. And how will you diagnose this syringomyelia? The investigation of choice is the MRI of the spine. And as such, if you take the treatment, if for syringomyelia, there is no known curative treatment. Only thing is that if you do a decompression at the foramen magnum, that can slow the progression of the disease. So that is about the syringomyelia, right? The third clinical scenario. Now coming to the fourth clinical scenario, a 34-year-old woman complains of generalized weakness in her muscles, diplopia, and weakening of her voice if talking for longer than 30 seconds. Examination reveals the bilateral ptosis. So now you see here, the individual is complaining of diplopia, very important symptom, and weakening of her voice if talking longer than 30 seconds. So after the usage of the muscles, there is development of weakness. So where will you have this? You will have this in patients with the myasthenia gravis, which is an autoimmune disease. And these autoimmune diseases, they are very common in women. So now what is the answer here? The answer is the myasthenia gravis. So myasthenia gravis is what? It is an autoimmune disorder. It's an acquired autoimmune disease which is characterized by muscle weakness and as well as the fatigability. And what are the antibodies? So if you take this myasthenia gravis, it is a neuromuscular junction disorder and it is a postsynaptic, right? It is a postsynaptic neuromuscular junction disorder. So in this individual, you have the presence of the antibodies. So what are these antibodies? They are anti-acetylcholine receptor antibodies, right? They are anti-acetylcholine receptor antibodies. Now because this is an autoimmune disorder, it is associated with other autoimmune disorders as well. And what are the other autoimmune disorders? That includes the thyroid diseases like either your Graves' disease or the Hashimoto's disease. Now in these patients with myasthenia gravis, what is the earliest muscle that is being affected in myasthenia gravis? The earliest muscle that is being affected in myasthenia gravis is the levator palpebrae superioris. And because of the involvement of levator palpebrae superioris muscle, the earliest manifestation is the ptosis. And other extraocular muscles and bulbar weakness also will be present. And weakness of the facial muscles is also very common. Now, these patients, because of the weakness of the facial muscles, whenever they try to smile, right? Whenever they try to smile, they will have an abnormal smile, and that is what is called as the myasthenic snarl. Why? Because there is unequal contraction of the facial muscles that will result in abnormality within the face. And even there will be weakness of flexors and extensors of the neck. Because of the weakness of flexors and extensors of the neck, the individual will be also having the dropping of the head. And coming to the muscles of the limb, proximal muscles are more commonly affected than compared to that of the distal muscles. So let me just give you the summary of the involvement of the muscles in myasthenia gravis. So the first muscle that is being affected is the levator palpebrae superioris muscle. And these individuals, they will have, because of that, the ptosis. And there is also extraocular muscle involvement resulting in diplopia. And other muscles are, there will be muscles of mastication which are being affected, because of which there will be dropping of the jaw or drooping of the jaw. And swallowing and speech is also affected. That is because of the involvement of pharyngeal and laryngeal muscles. And they will have abnormal facial expression because of weakness within the facial muscles. And there will be dropping of the jaw and there will be difficulty in chewing. Why is that they will have difficulty in chewing? That is because of involvement of muscles of mastication. And within the limbs, if you see, proximal muscles are more commonly affected than distal muscles. And because of the involvement of flexors and extensors of the neck, there will be neck dropping. Right, there will be neck dropping. And after the involvement of all these skeletal muscles, if the severity of the myasthenia is more, then there will be involvement of the respiratory muscles also. Once there is involvement of respiratory muscles, the individual will develop respiratory failure. right? And what type of respiratory failure? It will be type 2 respiratory failure. That is what you will see in case of the myasthenia gravis. And the deep tendon reflexes, they are rarely involved, and there will be no accompanying sensory loss. There will be no accompanying sensory loss, and deep tendon reflexes are rarely involved. Then coming to the investigations. So we have acetylcholine receptor antibody test, repetitive nerve stimulation test, single fiber electromyography, and hydrophonium test. But what is the investigation of choice in myasthenia gravis? Investigation of choice is the single fiber electromyography. Then coming to what is the drug of choice. See, in case of mild myasthenia gravis, the pyridostigmine is the drug of choice. Whereas in case of moderate to severe form of myasthenia gravis, the drug of choice will be the corticosteroids. Now, so what is this? This is a neuromuscular junction disorder where the antibodies are formed against the NM receptors in myasthenia gravis. We have one more form of neuromuscular junction disorder, which is nothing but the Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome is also a neuromuscular junction disorder, but it is a presynaptic, right? It is a presynaptic nerve terminal disorder where the antibodies are formed against voltage gated calcium channels, right? Voltage gated calcium channels. And what is the very, very important malignancy associated with Lambert-Eaton myasthenic syndrome is, it is the small cell carcinoma of the lung. Whereas what is the malignancy which is associated with the development of myasthenia gravis? That will be thymic abnormalities, that is thymoma and as well as thymic hyperplasia. So this is what is the difference in the malignancy associated with myasthenia and Lambert-Eaton myasthenic syndrome. And clinically how they are different. In Lambert-Eaton myasthenic syndrome, muscle strength, it increases, and reflexes, they return back to normal with repeated contraction. Whereas in myasthenia, it is exactly opposite. On repeated contraction, that will give rise to more weakness, and there will be reduction of the reflexes. There will be reduction of the deep tendon reflexes. That is what you will have in case of Lambert-Eaton myasthenic syndrome. And in Lambert-Eaton myasthenic syndrome, what is the drug of choice? It is 3,4-diamino-pyrimidine. That is the drug of choice in case of Lambert-Eaton myasthenic syndrome. So this is about the discussion on neuromuscular junction disorder. And the last clinical scenario, a 15-year-old boy is found to have several coffee-colored patches on his body. Slit lamp examination reveals the presence of Lish nodules. So, seen in child, coffee-colored patches, Lish nodules. What is this suggestive of? This is suggestive of a neurocutaneous syndrome. And what is that particular neurocutaneous syndrome? It is nothing but neurofibromatosis type 1. It is not type 2. It is neurofibromatosis type 1. And this neurofibromatosis type 1, it is also known as von Recklinghausen's disease, and the type of inheritance is autosomal dominant type of inheritance. And the problem in this neurofibromatosis type 1 is decreased production of the neurofibrin, fibromin. And what are the various diagnostic criteria for neurofibromatosis type 1? Please remember this mnemonic, that is CAFE spot. What is this CAFE spot? The C stands for CAFU spots. A stands for the axillary freckling or inguinal freckling. F stands for fibroma. E stands for I, the presence of the Lish nodules. S stands for skeletal abnormalities. The most common skeletal abnormality will be in the form of scoliosis. P stands for the positive family history. OT stands for the optic tumor, which is nothing but glioma. So this is what is the mnemonic for neurofibromatosis type 1. Now let me show you all these abnormalities. So this is the most common orthopedic manifestation of neurofibromatosis type 1, which is nothing but your scoliosis. Next is the presence of the CAFU spots. See, how many CAFU spots should be there? Now, in prepubertal, the number of CAFU spots, it should be definitely 6 or more, right? The number of CAFU spots should be 6 or more, but the diameter of them or dimension of them, it should be 5 mm in prepubertal individuals, whereas the dimension should be 15 mm in case of post-pubertal individuals. So this is about the CAFU spots. Then Next important is the axillary freckling. Now, if you take this axillary freckling, they are the freckles. They are present either in the axillary area or in the inguinal area, and they are small circular spots on the skin, and they are very darker. Right? You can see that they are very darker. So this is about your axillary or inguinal freckling. And next thing is the neurofibromas. See, a neurofibroma is a benign nerve sheath tumor in the peripheral nervous system. And how many neurofibromas should be there for the diagnosis? 2 or more neurofibromas should be there for the diagnosis. And next, this is your Lisch nodules. See, this particular Lisch nodules, they are melanocytic hamartomas. They are dome-shaped elevations from the surface of the iris. And what is the color of this? They are clear to yellow or brown. That is about your Lisch nodules. And another important skeletal abnormality is in the form of the sphenoid dysplasia. It is in the form of sphenoid dysplasia. Okay, right. So having discussed all these abnormalities, so this is the mnemonic for your neurofibromatosis type 1. So out of these, how many should be there? So there are totally 7. Out of these, at least 2 should be there for diagnosis of neurofibromatosis type 1. So this completes the discussion of the 5 important clinical scenarios related to the today's INI-CET revision series. And before winding up the session, so please answer this question. Yes, please answer this question in the comment section. Chromosomal abnormality in neurofibromatosis type 1 is. So with this, I'll wind up the today's session, get back to you tomorrow with the another important clinical series.